Hello, class. This is Professor Roberts, and today we're going to talk about hormone regulation, specifically focusing on thyroid disorders and all the things that the thyroid does to your body, and why it is so important to have a balanced thyroid hormone. So today we're going to talk about thyroid problems. Your thyroid gland is one of the most common endocrine disorders that you can have in your body. The thyroid is like a little butterfly shaped gland that is found in your neck, and a lot of people end up having problems here. It's very common. The thyroid hormones that are secreted from the gland are T4, T3, and a lot of times they regulate your metabolism. Certain people that have thyroid problems can be seen physically with certain abnormalities as a goiter. A goiter can be a large, sometimes people consider it like a large knot in your throat that at times can be uneasy to the eye, but it is another way we can tell if someone is having some type of problem with their thyroid gland. The importance of the thyroid is it helps with metabolism, body temperature, heart rate, digestion, mood, and energy levels. The thyroid works with the pituitary gland, which is very close to that thyroid area, and it helps to maintain balance and homeostasis throughout the body. A healthy thyroid ensures your body functions smoothly. And you've heard of homeostasis throughout all your anatomy and physiology classes. But it's just important to understand that this gland is very important for your body as a whole. When it acts up in children, sometimes it can cause problems with growth and development. Within adults, it has a lot of things to do with like weight loss and how we metabolize and digest our foods. So we're going to talk about the two ends of the spectrum being hyperthyroidism, which would be like an overactive thyroid, and hypoactive thyroidism, which is an underactive thyroid. So it's two ends of the spectrum that we're going to talk about today. So the effects that the thyroid hormone can have on the body. It can affect your heart, your eyes, skin, nails, reproductive system. An influx or decrease in this hormone can really negatively affect or even impacts a person's brain function and mood as far as depression. Often hypothyroidism can be mistaken as depression. Hyperthyroidism increases the heart rate, causes palpitations, and can lead to arrhythmias or high blood pressure. Dysfunction in people with hypothyroidism in your heart, it can slow your heart rate down. It can cause bradycardia, low blood pressure, and fluid retention. A lot of times, often when we do an assessment of someone with hypothyroidism, they may have a puffier face, and I'll show you that in slides that are to come. Eyes can affect your, it can cause your eyes to bulge, eye dryness. You can have a sensitivity to light due to a thyroid imbalance. Skin. Hyperthyroidism sometimes makes the skin thin and warm and sweaty. Hypothyroidism can cause dry, pale, and rough skin. Reproductive system in a whole. For women, having hypothyroidism can mess with your menses, and it can also affect childbirth or even the act of conceiving. So as you can see, again, the thyroid hormone helps with growth and development of tissue and tissue repair. Fluid balances, it controls your metabolic rate. It can also affect your circadian rhythm, and it can just overall affect your health and appearance. Thyroidism. From these slides, you should be able to understand the signs and symptoms, or what we call cues, of a patient with hyperthyroidism, how they present, what may have caused them to have hyperthyroidism, whether it was from an autoimmune disease or even excess in iodine. Certain complications related to hyperthyroidism. We should be able to identify such things as thyroid toxidosis or thyroid storm, or even how some thyroid patients can end up with long-standing heart problems, such as atrial fibrillation or heart failure. Lastly, as the nurse, what are you going to do to treat hyperthyroidism, right? What are your actions? And what are you going to teach your patient as they live throughout this process? Because hyperthyroidism can be lifelong. Hyperthyroidism is hyperactivity of the thyroid gland, with sustained increase in synthesis and release of thyroid hormones. What does that mean? That thyroid is working so hard, it is overactive, right? Something in your body is telling your thyroid gland and the rest of your hormones, like, hey, I don't have enough TSH, right? It could be a real problem or it could be a synthetic problem. Hyperthyroidism can cause a lot of different symptoms, and sometimes patients really don't know that they're having a lot of problems related to hyperthyroidism until they go to their primary care provider, right? Some people just say, "Hey, I've been sweating a lot. I need to figure out what's going on with me," or I've been having a lot of loose stools, and they think it's something GI related, but overall it's really their thyroid, because your thyroid has a big part in really everything that you do, right? Patients a lot of times present with weight loss or despite an increased appetite, which means they're losing weight and they're always hungry. They might even have a sense more of irritability and tremors, which leads a lot of patients going to like a psychiatrist. And then often psychiatrists or any type of healthcare, mental health provider will say, hey, maybe you should get your thyroid checked, right? When completing an assessment on a patient with hyperthyroidism, going back to the previous slide, remember that the thyroid affects multiple organs in the body. So with this overactive thyroid, you can think of everything or all of the organs moving faster, right? So if you're doing a neurovascular assessment on this patient, you can assume the nervousness, the irritability, insomnia, tremors, right? This patient is moving faster. Weight loss, strong feelings of hunger and diarrhea. This patient's GI system is constantly moving and they are hungry and they want to eat. So this patient is eating, but they're not gaining any weight. They're actually losing weight. This patient may present with an enlarged thyroid, and that's something you can probably see in a objective assessment, right? You may see the bulging in the neck. This is because the thyroid is working so hard that it begins to enlarge. This patient may also have fragile fingernails or shaking hands and clubbing of the digits. Okay. If you think about their heart moving faster, they're having increased heart rate and irritability and high blood pressure and arrhythmias, right? Arrhythmias are beats, right? Instead of this patient's heart beating normally, they're having an increased heart rate. Their skin will be warm and moist. Think of this patient as always being wet. Increased body temperature, so they're always sweating. They can have muscle cramps and muscle weakness just because their muscles are always being used. And when you think of the skin as well as the hair, they have broken hair or hair loss, right? Thinning of the hair. Um, so we like to consider this patient wet and kind of like bald in some areas. This patient may also have bulging of the eyes and clubbing of the digits. We consider this a hallmark sign. It's called exophthalmos. It's the bulging of the eyes that we talked about. And the acropatchy, that's the clubbing of the fingernails. If you look at the picture, and you can probably look at your own fingernails to see. A lot of times, clubbing of the fingernails has something to do with oxygenation. And just think about this patient and their body process and how they have like the increased energy and their cells are always being used and in a flux. So this brings us to Graves' disease. Graves' disease is an autoimmune disease characterized by thyroid enlargement and excessive thyroid excretion. What does it mean to be an autoimmune disease? It basically means that at some point your body decided to attack itself, right? Your immune system decided to attack a part of your body. Now, this is about 75% of the hyperthyroidism cases. So that means another 25% of hyperthyroidism cases is not considered Graves' disease. Graves' disease is considered idiopathic. That basically means we do not know the exact cause. At some point, some trigger tells your body, hey, I want you to start attacking your thyroid system. And that is when the patient goes into hyperthyroidism. As you can see, the the cues are relatively the same, right? That sweating, the bulging of the eyes, nausea and diarrhea, right? That muscle weakness and tremors. So it presents the same. The only way we would know is if this was Graves' disease is we would do a test to see if your antibodies are attacking that part of your body. So how do we diagnose your patient with hyperthyroidism? We would do a history and physical. What does that mean? We would gather all of this information, right? All of those cues that you saw that patient have, and we would say, hey, you might have a thyroid disorder, right? You're having the nervousness, you're having the diarrhea, and get the weight loss, right? This unexpected weight loss. Okay. Even if you palpate around someone's neck, right? If you do a ear, nose, eyes, and throat exam, and you say, "Hey, I feel maybe like a goiter or something like that," that's a part of your history and physical assessment, right? You can do an eye exam, an ophthalmologic exam, and an ECG. Remember, one of the cues were arrhythmias and palpitations. So you will be able to see your patient's cardiac rhythm on an ECG. ECG is electrocardiogram. Laboratory tests that would help us determine if your patient was having hyperthyroidism. When people test for hyperthyroidism, they start with the TSH levels. That is the level that is excreted by your thyroid. And we would take that and also then look at your T4 and your T3. And sometimes when we look at it, we can decide whether this patient might have hyper or hypothyroidism. Thyroid antibodies. This is the test where we would try to see if the antibodies in your body and your thyroid is attacking itself. Right? It's thyroid paradoxase antibody, a TPO test. And we would look at your total serum T3 and T4, and your radioactive iodine uptake. Remember, the thyroid excretes iodine. So this is a laboratory test that will help us see about how much iodine you currently have in your body to see if it's a deficit somewhere. For a plan, right? We have taken this patient, we looked at all of their cues, right? We've done our health assessment, our physical. We have taken their blood. We have also maybe even checked for antibodies to see if it's just regular hyperthyroidism or Graves' disease. So now that we know for sure this patient has hyperthyroidism, what is the plan, right? So this patient has too much thyroid in their body. We need to figure out how we can decrease the thyroid, which will probably either be drug therapy, radiation therapy, or surgical therapy. Nutritional therapy is there as well. When we think about our patient, all the cues that they had, if they are losing weight, right, because of the hyperthyroidism, that's a problem. Now they're malnutrition. So we need to have nutritional therapy in there somewhere. Now when we get to this pharmacology piece of the process, CJMM process, I want you to think of that. Think about the nurse taking action and actually doing something. I also want you to stop and think about how we talked about body processes and how usually in a body a drug is used to combat some type of even increase or decrease of a normal function in the body, a normal system. and how it functions in the body. A patient with hyperthyroidism is having too much activity in their thyroid gland. So that's why you need an anti-thyroid drug to combat that hyperactivity. Methimazole and propylthiouracil can be given for the patient to decrease the thyroid activity. Iodine, also known as SSKI, the K is for potassium, is a potassium and iodine derivative, and what it does is it decreases that thyroid activity in the body. SSKI can also be used for patients who are getting radioactive iodine therapy, and that's something that we'll talk about in a few slides ahead. You may also see a patient with hyperthyroidism be prescribed a beta blocker. And I want you to think of this in sense of the patient's cues. This patient is experiencing arrhythmias, palpitations, and tremors, and irritability, anxiousness. A beta blocker slows your heart rate down, which will help mask those symptoms, right? It will slow your heart rate, it will help with the palpitations, it will slow your heart rate, and it'll also help with that systemic effect of the patient feeling nervous. For instance, sometimes even with testing anxiety, we can give people propranolol, right? It blocks beta in the heart and slows you down a little bit. So that is the indication for a patient with hyperthyroidism. It's going to help with those cardiovascular and neural symptoms. I'm going to talk about a complication of hyperthyroidism. And I'd like you to think of this as a spectrum. If your patient is experiencing hyperthyroidism, and let's say they ignore the cues that they have going on, they ignore the tremors, the cardiovascular cues, they ignore the weight loss and the excess hunger, right, and the sweating and the irritability, and they just pass it on as, oh, my body's going through changes or anything, or they just don't seek out help. This patient can end up with thyrotoxicosis. This is an emergency event. It requires aggressive treatment, and often this patient will be admitted to the ICU. We will give medications that block thyroid hormone production and the sympathetic nervous system effects. We'll monitor for dysrhythmias because at this point, this patient is on the farther end of the hyperthyroid spectrum. They're definitely having dysrhythmias, and that can lead to decompensation. Right? If they are in a dysrhythmia for too long, their heart can actually give out. Ensuring adequate oxygen. This patient might need oxygen therapy or even an IV fluid replacement and electrolyte loss, because if this patient is sweating excessively and having diarrhea, they're losing electrolytes, they're losing fluids, they are having a fluid volume loss, and that needs to be replaced with fluid and electrolytes. This is important again for a patient who is not only having diarrhea but vomiting as well. Right? So think about them losing fluid orally through their GI system and also sweating profusely. This patient will also have heat intolerance, right? Because remember at the beginning we said that that a thyroid disorder can affect how you regulate your temperature. This patient might have a heat intolerance. And when we talked about the cues as far as irritability and nervousness, now it's to the extreme. This patient could be having mood changes. So now that your patient is out of that acute phase and they're no longer having signs and symptoms of thyroid toxicosis, right, it is time to add in the education piece. Granted, we educate our patients along the way, right? We teach them, like, hey, this might have happened because of medication adherence problems. But sometimes we have to break it down a little further, right? Was your patient not taking their medication because they couldn't afford their medications? Was your patient under a lot of stress? Was there an infection or some kind of trigger? Oftentimes when people become sick, they throw their daily habits out the window, right? If you had the flu for a few days, it takes you out of your cycle, and you're not taking your medications as you should, it's not just saying like within a week of not taking this medication, a patient would um, end up with a thyroid storm. But a lot of times it's all about habits, right? So a lot of times we want to talk to our patients to see, hey, what was the problem with you taking your medications? Was it financial, right? Are you having problems access wise, like actually getting to the doctor or getting to get your medications? These are a part of like education and like long term care that we start to implement, right? Your patient should be able to follow up regularly because with any thyroid disorder, blood tests have to be frequent to make sure that your patient is at the best optimal drug level to correct this imbalance. So, a lot of times we work close with social work or case managers to assist your patient to see if there's any problems with adherence to medication or the plan of care provided by the physician. And if it is financial, we always recommend they go to social work. And if it is a care issue or even maybe a healthcare literacy issue, then we might get a care manager on board to assist us with caring with the patient after discharge. In the planning phase on during the disease process, when we try to figure out, hey, what can we do with this hyperactive thyroid, we mentioned surgery. So that's when a thyroidectomy comes into play. So as you can see here, a thyroidectomy, they will take a portion of your thyroid, or you can have a partial thyroidectomy or a total thyroidectomy. So you'll assess after this patient has surgery, you'll assess their vital signs every 15 minutes until they're stable, and then every 30 minutes for the first 24 hours after surgery. You need to monitor this patient's airway and respiratory status. This is important because, of course, the thyroid is very close to the trachea and the windpipe. And let's say during the surgery, maybe that respiratory system was compromised. You also want to monitor for calcium levels. This is because there is another small organ called the parathyroid, and it's right next to the thyroid. The parathyroid is responsible for calcium. And if it is, let's say, nicked or hit during surgery, it can cause a flux in calcium levels. Well, what does calcium do? If you remember from previous classes, calcium can affect your heart rhythm and your muscles, and it can actually send you into a arrhythmia or cardiac arrest. You want to keep this patient in a semi-follower's head position to support the neck and the head with pillows. This is proper body alignment, and just think about it, your patient just had neck surgery. Provide comfort measures. Comfort measures, pain therapy, this patient might be in pain. And then you want to monitor dressing status, right? Bleeding. Anytime you have a post-surgical patient, you always want to think of bleeding and blood loss. So you need to monitor their dressing to make sure that you want to monitor their dressing to make sure that your patient isn't having any bleeding. Radioactive iodine therapy is a nuclear medicine treatment that uses a low dose of radiation to treat hyperthyroidism or an overactive thyroid. Because because a radioactive treatment is being used, the goal is to limit radiation exposure to others. The patient is already exposed to radioactivity, but is needed as it for a part of their treatment. But what if this patient goes home and they're around others? So that's why we say the goal is to limit radiation exposure to others. We want to teach the family and the patient that the patient needs their own designated toilet facilities, right? Because their secretions will be radioactive, right? So they need to be able to use their own toilet if possible. We also need to teach the patient that they need to flush the toilet 2 to 3 times. Again, this patient's urine will be radioactive. They need to do their own separate laundry. They do not need to be preparing food for others.
especially food that requires prolonged handling with bare hands, right? This means that they should use gloves. And they should also avoid contact to pregnant women and children for 7 days after therapy. Pregnant women should not have any type of radioactive radiation exposure, in children as well.
So hypothyroidism occurs when the thyroid gland produces too little thyroid hormone. So now we're on the slower end of the spectrum, right? This can lead to a slower metabolism, slower growth of the body, also leaving your body out of homeostasis. These patients sometimes present with weight gain, and the opposite is a lot of times true with hyperthyroidism versus hypothyroidism, right? Hypo, we see weight gain. Hyper, we see weight loss. With hyperthyroidism, we see irritability, like you think fast, right? The patient's running into their grave. Hypothyroidism, this patient is a little slower, right? They're constipated, they're fatigued. So think about it that way. Also, I always say if we have two disease processes at the end of the spectrum, we need to educate ourselves and kind of study these separately. So when you study hyperthyroidism, please take a break in between moving on to hypothyroidism. This is going to, again, trick your brain to think, hey, these are separate disease processes. Again, hypothyroidism is a deficiency of the thyroid hormone that causes a general slowing of the metabolic rate. These patients can sometimes, and I would like you to look at the picture, with the puffiness of the face and the eyes, and the swelling around the eyelids. They may have dry, rough, or even pale skin. You can see the neck is bigger, and this patient is having like swelling around that neckline as well. This patient might have memory problems and brain fog. So there's a lot of differences in how they present, but this picture is important, and you can look at other pictures of people with hypothyroidism. When we start breaking down disease processes, it is always great to have a picture reference, and then sometimes the textbook provides a lot of good pictures. Um, when we think of hyperthyroidism, always think of the exothalamus, right? The patient, the smaller, skinnier patient with the bulging eyes. And then the hypothyroidism patient, they're puffier, right? They're a little swollen. They might have thin hair as well and have hair loss. Even in the eyebrows. You see how his eyebrows are sparse, right? So start thinking of like general cues, especially for my visual learners, okay? A picture might actually help you break down and go through those cues. And we'll go through more of the cues on our next slide.
And again, I do not recommend you compare and contrast the two. You should treat them as their own disease process. So when you get to cues, you can easily identify the difference between the two. This patient will be fatigued. Their skin will be cold and dry. They will experience hair loss, constipation, cold intolerance, and myxedema of the skin. This is a picture of myxedema of the skin. As you can see, the skin looks really leathery and it is not smooth. And it has a lot of dryness to it. If hyperthyroidism increases the body, hypothyroidism slows the body down. Constipation, the bowels are slowed down, right? Thinning of the hair and hair loss. Loss of eyebrow hair. Again, the thyroid can also be enlarged with hypothyroidism because it's not being stimulated. It's not enough TSH in the body to stimulate it, and it's again working harder. It can slow your heart rate down. It can cause a poor appetite. And in women, it can cause infertility and heavy menstrual cycles. It can cause carpal tunnel syndrome, and this patient will feel cool in the extremities and experience swelling of the limbs and the puffy face. So if you look back at the picture on the previous slide, how his face was really round and puffy, so we consider the puffiness kind of like a weight gain. Whereas if hyperthyroidism, they're losing weight, this patient will look more round and full of fluid. The thyroid gland does not produce enough thyroid hormone, and that is the problem here, right? So again, weight loss, poor memory, cold intolerance, and feeling of tiredness. Everything is slowing down with this patient. Diagnostic for hypothyroidism may appear similar to hyperthyroidism, right? You still want to get that history and physical assessment. You still want to get a serum TSH and then a free T. And then you also want a total serum T3 and a T4. And you also want to check for the presence of antibodies. So again, what would be the plan for this patient? Well, this patient doesn't have enough thyroid in the body. So we need to replace that thyroid. That's when thyroid hormone replacement medications come into play. We want to monitor thyroid hormone levels and adjust the dose if needed, because when we're giving levothyroxine, we need to make sure that the patient is at the adequate level of TSH. Nutrition therapy to promote weight loss. Again, this patient has more weight gain than compared to hyperthyroidism. And again, I always say anything you know for yourself or you teach about the disease process, you need to teach it to your patient, right? Or the caregiver. Because even though sometimes these emergencies we manage in an acute care setting, most of the time hyper and hypothyroidism will be managed at home. Levothyroxine is a thyroid replacing hormone. The brand name is called Synthroid, and I always remembered it as synthetic thyroid. Levothyroxine is the thyroid hormone stimulator that you'll see the most in your acute care setting. A lot of patients are on levothyroxine. With some of the nursing considerations is carefully monitor the patient with CVD risk who take this drug, right? Cardiovascular disease. Report pulse greater than 100 beats per minute or irregular heartbeat. Report chest pain, weight loss, nervousness, tremors, or insomnia. What does that sound like? To me, this sounds like I'm giving my patient fake thyroid to increase their thyroid, and now it's turning them into a hyperthyroid state. And that's exactly what can happen with levothyroxine. That's why it's important to monitor their levels to make sure that we are not giving them too much thyroid. This medication is best absorbed when the medication is taken first thing in the morning.
So with patients with hypothyroidism, you want to teach them that the overall signs and symptoms of that metabolism slowing, right? This will help them realize, like, hey, something doesn't feel right. I still feel off. I might need to go to my primary care provider. Teach them to never stop their medications without consulting their provider, because this is something that should be carefully looked at, right? It needs surveillance. It needs laboratory surveillance. Like the follow-up says regular thyroid function tests. Your patient should regularly be going to the provider to get their blood drawn. They need to know when to call the provider, right? If a patient isn't getting enough of a medication, it could be subtherapeutic. And they may start to experience some of those unexplained fatigue or facial swelling and actually lead to further complications such as myxedema coma. They should learn how to survive with this disease process, and it's a lifestyle, right? The importance of balance and rest. If you're tired, right, the importance of exercising regularly and staying hydrated, because that's a big part of hypothyroidism. You're already feeling that slowness, right, that slowing of the metabolism. So diet and a balanced lifestyle will actually help with this disease process.
So with hyper and hypothyroidism, we talked about how testing was important, right? Usually we test for the TSH and then we look at T4 to decide which spectrum we think the patient might be on. So when we draw a TSH lab, we look at that first. And if you see hyper, there is a case where TSH will be low for hyperthyroidism, and then high for hypothyroidism, and then low again for secondary hypothyroidism. But the T4 is only high with hyperthyroidism. So, for instance, if I ask a question, an NCLEX style question that said your patient presented with low TSH but high T4, you would know that your patient is being diagnosed with hyperthyroidism. But on the contrary, if I said your patient was admitted with a high TSH and a low T4, then you would know that your patient was diagnosed with hypothyroidism. So again, if we talk about thyroid disorders being on a spectrum, myodexacoma would be on the lower end of hypothyroidism. So this is also an emergency event. This patient might be experiencing drowsiness, lethargy, impairment of consciousness. They can go into a coma. They could be having serious diarrhea, low temperatures, hypotension, hypovolemia, hypoventilation, hyponatremia, and hypoglycemia. The plan for this patient is IV thyroid replacement. The thyroid replacement hormone will be IV so it can act faster. This patient will have IV fluid resuscitation because they are having hypotension and hypovolemia and hyponatremia. If they're hyponatremic, they'll get an IV replacement that will help bring up their sodium. And that's when you get into the management of electrolytes. They also can have hypoglycemia, and don't forget their blood sugar. Sugar is an electrolyte, so that's something that we would try to replace as well. Again, this is an emergency event. If you look at the picture with the young lady with the things on her cheeks, I don't know if you can see it very well, but she is intubated, right? So if she's hypoventilation, and she becomes impaired consciousness and she isn't breathing on her own, then she'll need to be intubated. If you look at image B, and you can see how the toenails and the skin is extremely dry. This is a patient I would like you to think about. Perhaps, for example, they were untreated with thyroidism and they ignored symptoms, or maybe they were on a synthroid medication, but it was subtherapeutic. It wasn't at the right concentration and they weren't getting enough of the synthetic thyroid to keep the patient from going into myxedema coma, excuse me. And then also the last picture is of ECG. This patient can be having bradycardia. So as you would see on here, you guys cannot read this yet, but this patient's heart rate will be very slow. And this chart is just used to show you the difference between the two. And remember that hyper is increased and hypo is decreased. And it just compares and contrasts the two disease processes. But don't forget, when you study them, it is important to study them separately, right? Hyperthyroidism, weight loss. Hypothyroidism, weight gain. Hyperthyroidism will have the increased appetite, whereas in hypothyroidism, they'll have the decreased appetite. The difference between intolerance of heat and cold and sensitivity to heat and cold. The difference between the cardiac tachycardia and bradycardia and palpitations. Hyperthyroidism, they'll experience diarrhea, and hypothyroidism, they'll experience constipation. You get into that neurological assessment. Hyperthyroid, hyperthyroidism will experience anxiety and nervousness and irritability, insomnia, tremors. Where hypothyroidism, their neurological system will be depressed. They'll have fatigue, depression, impaired memory, impaired concentration, and a mental fog. In hyperthyroidism, they'll have increased hair and nail growth and increased sweating. Now, hyperthyroidism can also have thinning of the hair, but in hypothyroidism, you see complete hair loss, and that can be on your head or even on your eyebrows. And this person will have thin, brittle nails and dry skin.